Thank you so much, sir, for that kind introduction. So the topic assigned to me is EUGR, that is extrauterine growth restriction. So I'll be covering this topic under the following headings. We will know what is this EUGR, what are the different etiologies, is there any classification available, and main thrust will be on how to prevent this in our day-to-day neonatal care practice, and how can we be more aggressive in nutrition. Like we're aggressive in ventilation. हम ना हमें 2 मिनट नहीं लगते ट्यूब डालने में, हमें 2 मिनट नहीं लगते सोचने में कि बच्चे को वेंटिलेट करना चाहिए कि नहीं करना चाहिए, ब्लड गैस भेजना चाहिए कि नहीं चाहिए, एक्सरे करना चाहिए। वैसे ही न्यूट्रिशन में वी शुड ऑलवेज बी एग्रेसिव कि इस बच्चे को फीड क्यों नहीं स्टार्ट कर सकते, रादर देन थिंकिंग कि करना है कि नहीं, क्वेश्चन शुड बी क्यों नहीं करना है। सो एक चीज जिसकी सोसाइटी में बहुत इंपॉर्टेंस है, दैट इज वेट। फ्रॉम लोहार टू सोनार, from airport to sabzi wala, they are all very peculiar about one thing, that is weight. 1 ग्राम भी आपको ज्यादा नहीं देंगे। Similarly, in our NICUs, we are very much worried about एक चीज जो SNCU से लेके level 3 NICU, level 4 NICU में anthropometry terms में common है, that is they at least weigh the baby. They may not be doing head circumference, they may not be measuring the length, but at least weight चाहे हफ्ते में एक बार या दिन में एक बार करेंगे जरूर। Why we are worried about weight? We know that because from the data, जितना भी कल से data present हो रहा है, ultimately, including the department का जो logo है, that is intact survival. Now the neonatology is shifting from, पहले होता था कि सिर्फ बचाना है, अब aim है सिर्फ बचाना नहीं है, but बचाना है with intact survival. So we all talk in terms of brain gain. That is, अगर lesser the gestation, lesser the weight, more is the risk of immediate as well as long-term complication. जब भी हम न्यूरोलॉजी में लॉन्ग टर्म आउटकम्स की बात करते हैं, द मेन थ्रस्ट इज ऑन 2 थिंग्स, आइदर बीपीडी और न्यूरोलॉजिकल आउटकम। एंड हियर इन दिस स्लाइड वी सी दैट विद द फॉलिंग वेट द रिस्क ऑफ न्यूरो डेवलपमेंटल इंपेयरमेंट इंक्रीजेस, रिस्क ऑफ सेरेब्रल पॉल्सी इंक्रीजेस। तो दैट्स व्हाई वी आर वरीड कि बच्चे का वेट बढ़ रहा है कि नहीं। सुबह जब आप काउंसलिंग करते हैं तो पेरेंट 2 ही क्वेश्चन पूछते हैं, बच्चे ने सुसु पॉटी किया कि नहीं, वजन कितना बढ़ा है, ठीक है, रेस्ट दे आर नॉट वरीड। Now the problem is हम वेट तो करते हैं, then problem क्या है? The problem is कि if you are not vigilant, just like Anish mentioned that we should be doing nutritional rounds. If you are not regularly plotting this weight, head circumference, length as a part of our medical care, then by the time we diagnose the baby with growth faltering, it's already too late. You cannot do much. So it should be a routine process, and the thrust should not be on the management, but on picking these babies early, and always have a dashboard. लाइक पहले हम सिर्फ हार्ट रेट मेजर करते थे, सैचुरेशन मॉनिटर मेजर करते थे, आज हमारे पास NIRS की बात करते हैं, हम ट्रांसक्यूटेनियस पल्स ऑक्सीमीटर की बात करते हैं। बट क्या हमने कभी दिमाग लगाया कि यार एक न्यूट्रिशन बोर्ड भी हो कि बच्चे को लगाए, उसको पता चले इतनी कैलोरीज जानी थी, इतना डेफिसिट है, इतना प्रोटीन जाना चाहिए था, इतना प्रोटीन डेफिसिट है। सो दैट न्यूट्रिशन डैशबोर्ड कंसेप्ट शुड बी देयर। Unless until that comes in, will always be late comers. Now coming to the topic per se, EUGR is whenever our babies they have a poor weight gain, objective terms में बात करें, whenever their weight is less than 10 centile at 36 weeks of gestation or at discharge, we classify them these as EUGR. It is almost universal. Almost 100% of the ELBW babies, they will have some degrees of EUGR, and in the VLBWs the rate is as high as 40 to 60%. And the incidence, as is expected, is inversely proportional to the gestational age. Smaller the baby, higher is the risk of EUGR. And therefore, every preterm birth, especially extreme premature birth, is a nutritional emergency. जैसे हम कहते हैं कि बच्चा साइनोसिस है, फटाफट ऑक्सीजन लगाओ, वैसे ही होना चाहिए कि बच्चा आ गया है NICU में, फटाफट न्यूट्रिशन लाइन एस्टैब्लिश करो, है ना। सबसे पहले हम जैसे कैन्युला डालते हैं, वैसे ही वी हैव टू एस्टैब्लिश दैट कट लाइन, either through parental nutrition or enteral nutrition, but that ABC should include D, where D is dextrose. And you should always question yourself, your juniors, your seniors, कि हमने dextrose के लिए क्या किया। So various definitions are there for classification, and no classification or no definition is complete. There are fallacies with that. Just for now, we talked about the weight. That is just 1 point measurement. If we measure, including your exams, if we measure you on just one exam basis or 1 day performance, we will never be able to judge that student properly. So that's why whenever the external comes for the exam, he always asks the HOD, how has this student been throughout the year? How is he performing? because just a single performance cannot judge the baby, whether baby or a clinician, whether he's a good or a bad clinician. Similarly, if we go by just 1 point reference that this baby is EUGR, we'll often label normal babies as EUGR. So it should be a multiple points of time, and the growth should be tracked rather than snapshot. So we have Z score definitions. Z scores are basically, we talked about yesterday, they are the deviation. How deviation is it from the median, from the reference gender as well as the gestation. And these are especially important in extremes. We know that the baby's weight is less than third centile, but kitna kam hai, that we'll know about from the Z score. Similarly, agar weight bahut zyada hai, more than 97 centile hai, but kitna zyada hai, again that Z score will tell us. So because of this variability in the definition, the incidence is hugely varied, and we often do not know whatever interventions we are doing in our NICUs, whether they are beneficial or not. We have already known that why we are worried about the normal growth is because growth has an impact both on the body development as well as neurological impairment. So brain in terms of increased risk of CP, attention deficit, hyperkinetic disorders, and body in terms of metabolic disorders. These babies, if they are not fed properly, they can have increased risk of coronary heart disease, increased risk of metabolic syndrome, increased risk of hypercholesteremia. So that's why this is something which we should be doing right from the time of the birth. And risk factors, anything which interferes with the maternal, placental, or the fetal health is going to have a bearing on the nutrition of the child which is going to be born. And similarly, in the postnatal period, any sickness, especially in the first 7 days of life, like IVH, like need for mechanical ventilation, is going to take a toll. Similarly, in diseases like PDA or NEC, where in diseases like BPD or PDA, where we restrict the amount of the fluid, to give those adequate calories in that much small amount of fluid, it is again a challenge. So these babies are again at the highest risk of EUGR. But in general, the nutrition starts right from the conception. Maternal nutrition has an important bearing on the fetal as well as the newborn health. So think in those terms. Avoid teen marriages, avoid good girl nutrition, proper immunization, good antenatal checkup, antenatal steroids. They are almost as important as we talk about the NICU nutrition. So the basic problem with the EUGR is that there is a mismatch between demand and supply. So unless and until we have to decrease this demand, which is not physiological, but what are the things which we can do is we can increase the supply and try to match the demands of these low birth weight babies. So why this EUGR happens? This is just a summary that these babies, whenever they are born, because of the various problems, because preterm birth is itself a pathological process. We have to understand that preterm birth is not something which is physiological, which is normal. If preterm birth is happening, it is happening because of a disease process, which is either there in the mother or uterus placenta or the baby itself. So these babies are born with high metabolic demand. They have cold stress. They are most of the time sick. They require NICU admission, so their demands are very high. And third trimester is the period where there is maximum excretion of glucose, amino acids to the tune of 3 to 3.5 grams per kg per day. And if we do not match this demand, these babies are going to suffer both in terms of weight gain and later on in terms of neurological outcome. The things which you cannot measure, you cannot improve. So before trying to improve anything in your NICUs, you just first start measuring it. Just like we don't have data, we may talk about, but unless and until we have data, we cannot say that we are improving. That's why QI projects are come into place. What they actually do is they measure the things up kar kya rahe hain. They tell you about the facts which you are doing in ICU and then they build upon it. Similarly, start measuring growth. If I have just 1 point to tell from this presentation and you want to carry home is just plot weight, head circumference, weight daily, head circumference and length at least weekly once and try to see the growth chart. Just like आपको ABG में interest होता है कि ABG क्या है इसका, वैसे आपका growth chart में interest develop होना चाहिए कि इसका growth chart दिखाओ, head circumference कितना बड़ा है, length कितना बड़ा है, is it normal or abnormal? If abnormal, क्यों नहीं बढ़ा? ठीक है, so that is one of the most important take home messages from this lecture. And remember that weight alone will never give you the exact lean body mass. Remember, weight can be increased just giving IV fluids, but that weight is not the actual weight which we want to gain. It has to be in terms of lean body mass, and something which correlates actually with the lean body mass is the length rather than the weight. And similarly, we know that अगर हमें एक चीज clinical examination में देखनी होती है to know whether this baby is going to grow well or develop well is head circumference. If baby's head is growing well, we know that he is going to have at least good outcome. He will not be severely disabled. And similarly, head circumference is equally important and you should measure it. The normal parameters which we aim for is the preterm baby should gain at least 15 to 20 grams per kg per day with a head circumference of 1 to 1.4 centimeter, 0.9 centimeter, length of 1 to 1.4 centimeter. But despite these targets, despite achieving these targets, many babies still land in EUGR. Why? This is because exact measurement, they do not track the growth velocity. So this is just a measurement. Just relying on a single measurement is not going to help. You have to track these babies, track their growth, track their centiles, and then accordingly decide. Now, which growth chart to plot, we have already discussed, but in a nutshell, for late preterm term babies, you can plot intergrowth because only 40 babies were there who were less than 34 weeks. So this growth chart is not good for babies for less than 34 weeks. And in our unit for 34 weeker and majority of the other units, we use Pentel. And now something, the main aim of me presenting the lecture is to sensitize our young generation of neonatologists to these growth charts. So this is one of the Pentel charts. It comes separately for boys and girls. So here we have 3 parameters we discussed about. So this is what happens actually is that whenever this is a 27 weeker, so baby is born postnatally, we expect some weight loss because of the physiological diuresis. And usually by day 7 to 10, day 10, they regain birth weight and then they follow the centiles. So this is how a normal growth chart looks like. Same is true for the head circumference and same is true for the length. After initial physiological loss, they start gaining their centiles. Now this is the other baby. So can somebody tell me whether this is normal or abnormal? So let's go one by one. So this is a 25 weeker. He was born with a weight roughly around 50th centile, and same is true for the head circumference and length. So what is abnormal in this baby, if we go by definition, is that at 36 weeks, his weight is less than 10 centile. So is it EUGR? It is still the first line is 3rd centile, the second line is 10th centile, and the third is the 50th centile. So here you can see it is still less than the 10th centile at 36 weeks. So is this baby EUGR? If no, why? If yes, you are passed. No more questions. No, just answer me, is it EUGR? So the answer is no. This is not an EUGR. This is, remember that this is a 24 weeker. The catch-up growth will not occur so fast. Again, you are here seeing only weight. Look at the other parameters. The other parameters, the सबसे पहले catch-up growth होती है head circumference. See, the head circumference is already catched up. The length is also about to increase. So when you follow these babies, इसी baby को जब हम follow करेंगे, then in the next few weeks, this again, ये जो weight है, this will reach the normal growth potential, normal genetic potential. And if you go by the trajectory, it is following the centiles. So this is not EUGR. ठीक है? So हमेशा लकीर का फकीर नहीं बनना है. Always have multiple points. That's what happens. If you do just weight or head circumference once in a month, so you're always going to label erroneously that these babies is EUGR. Always follow the trend and always look at the other parameters also. So this is one more baby. So this was again a preterm 28 weeker. So how do you interpret this growth chart? Is it normal, abnormal? So again, growth chart हम plot क्यों करते हैं? 2 चीजों की वजह से. एक जब बच्चा पैदा होता है, we want to know whether this baby is AGA, SGA or LGA. वो क्यों करते हैं? Because SGA और LGA में they are more likely to have complications like hypoglycemia, hypocalcemia, so they need more monitoring. Second thing, हम क्यों plot करते हैं? To know whether my baby is growing well or not, because that is going to have both short term as well as long term consequences. तो पहला जो हमारा aim था, we saw that this baby's weight is around 50th centile, right? Head circumference कितना है? कौन सी centile पे? 90, and same is true for the length, right? So weight is on the lesser centiles compared to head circumference length. So क्या हुआ होगा? ऐसा क्यों? So this mother had eclampsia. So this baby had some IUGR. So there were some inhibitory factors inside the womb which were preventing his growth potential to reach his genetic potential. अब एक बार जब ये बच्चा पैदा हो गया, so that inhibitory environment has gone. So now this baby will go on to touch his normal centile, जिसका growth potential according to genetics, just like the other centiles. Okay, so again, this is a normal baby. And there was some incidence of IUGR. एक बार जब वो बच्चा पैदा हो गया, the inhibitory environment, he came out of that inhibitory environment, and he has again reached his growth potential, which is as per the genetics. So apart from the nutrition, what we do in our analysis, it is also the genetic potential, which is going to determine the exact weight that baby is going to have. So this is one more baby. Tell me about this growth chart. Is this baby obese? Overweight? Overweight नहीं है तो क्यों नहीं? Weight is almost 97 centile. So look at the other two. All parameters are on the higher centiles. So this is a constitutionally large baby. So nothing to worry. After initial weight loss, which is expected, he's again going back to his centiles. So again, this is a normal. So this was a 28 weeker, not returned to his birth centiles, but child is again not overweight because all the centiles are on the higher side. What about this baby? What is the difference between this graph and this graph? वहां पे तीनों parameters are on the higher centiles. Look at this graph. Weight and length is roughly around 50th centile, and weight is on the 97th centile. Again, this is because of the in utero environment. Because of the maternal diabetes, his weight gain was more. अब जब ये पैदा होगा तो इसका क्या होगा? Weight loss होगा, लेकिन कभी भी अपने normal weight पे नहीं देगा, because that weight was not normal for this baby. It was excessive because of the pathological process, in utero pathological process. And once this baby is born, he will lose some weight and then go back to his genetic potential. So again, that is how this LGA baby is different from the constitutionally large baby. Now this is an SGA baby, normal abnormal. Okay, that shows अगर यही में blood gas लगाया होता सब एक साथ बोलते acidosis, metabolic acidosis, respiratory acidosis, because that gives us thrill. Intubate किया तो कुछ किया, CPAP पर डाला तो क्या किया, ये तो सिस्टर भी डाल देगी. Same is true for the growth charts. ये मेरा काम थोड़ी, ये तो सिस्टर करेगी. Okay, please go back home and practice plotting growth charts, and I will be very happy if some among you can post growth charts from their units regularly in the group. So this is again a SGA baby. He was born with a weight of around 10 centile, and same is also true for between 3 and 10 centile is head circumference and length. What happened? There is initial weight loss, but again is going back to his near normal centiles. But again, since this is following the trajectory of the graph, so this is again normal. Okay, this is not abnormal. This is not an EUGR baby. So again, this is a constitutionally small baby. So iska because the parents had short stature, and this is a constitutionally small child. And these babies are, despite their weight being less than 10 centile or around 10 centile, they don't have any long-term impairment because this is constitutional. That is the genetic potential. अगर बच्चे माँ बाप ही छोटे हैं तो अमिताभ बच्चन कहाँ से पैदा करेंगे? ठीक है, so you have to respect Chinese race versus European race versus Indian race. That is why we say don't extrapolate data from other countries. Okay, because their genetic potential is different, our genetic potential is different. What about this baby? Okay, so this is SGA baby, जहाँ initial weight around 10 centile था, loss हुआ, लेकिन again went back. ये constantly small नहीं है, and SGA babies they tend to regain weight faster or slower compared to AGA babies. Faster, okay, because they have less extracellular fluid, so their lean body mass is better, and they regain birth weight faster compared to AGA babies. At term babies का weight कब double होता है? 4 to 5 months. Do you know a preterm baby can double his weight in how many months? Is it more or less than the term baby? It is less, in 3 to 4 weeks. ठीक है, हर बड़ी चीज small packets में आती है. So these preterms are fighters. If you give them proper environment, proper nutrition, small things, they are going to flourish. Now this baby. What about this growth chart? Normal, abnormal. Excellent. So this is an abnormal. Here you can see that if you continue to follow this, he was an AGA baby, but his weight is not following centile, it is going away from the centiles. So this is an abnormal. Quite often these babies, this baby had a very horrible course in the NICU. He had IVH, BPD, got ventilated multiple times, had extubation failures. That's why his growth is faltering, and this is true for all the centile, all the head circumference, weight, and length. What about this baby? This is again an abnormal HGA baby who continues to grow away from the centiles. And again, whenever they continue to falter away from the centiles, always look for the underlying cause. Quite often it may be hyponatremia, it may be underlying sepsis like UTI or anemia. And this is something which many parents commit in the OPD and they boast. बच्चे का weight हमने gain करवा दिया. This baby was fed every hourly. पहले breast feeding, उसके बाद formula feeding. क्योंकि मेरे पड़ोसी के बच्चा है same age का है, उसका weight 7 किलो, मेरे बच्चे का 3 किलो है. ठीक है, so this is an overfeeding. ठीक है, sometimes excessive everything is bad. This was an overfeeding and this was excessive weight gain, because you can see the other centiles, they are here around 50-60 centile, and this is the weight is around near between 70th centile, whereas the length is around 15 centile. So remember that prevention is the only key. If you do not plot the growth, do not pick up these babies, you are not going to treat these babies. So prevention holds the key. And the basic rule is to maintain the demand, to maintain the supply according to the demand. The nutrition has to be baby specific. You cannot have a blanket therapy for all the babies. That is true for babies even with the similar gestation, because the illness is going to be different, the morbidities are going to be different, and their requirements are going to be individualized, not a one blanket fits all size. Already has been discussed that whenever baby is born, establish the gut line as soon as possible in the form of man, that is minimal enteral nutrition. Ventilation, umbilical lines, shock with minimal inotropes is not a contraindication to men. You can start these babies 10 to 15 ml per kg per day. And remember that every 1 gram of protein you add to their feeds, either enterally or parentally, they are going to have better neurodevelopment outcome, and same is true for the calories also. Always, if you're not able to enteral feed these babies completely, you can always have a combination of two. That is some men and rest by the TPN. Now the rationale for this aggressive therapy is, we already discussed that these babies are devoid of stores, they lack stores, they have high an ICU admission rate, they have cold stress, they have illness, they have sometimes the sepsis is the cause of the preterm birth, so the demand is very high. And unless and until you meet this demand, you tailor-made the nutrition according to the individual baby, these babies are going to lag, and that lag is going to continue even after discharge. So menace can be given in almost all babies. There's hardly any contraindication, and benefits have already been discussed, that it decreases the time to full feeds and it does not increase the risk of NIC. Amino acids should be started right on the day one. Do not think that 4 बज गए कल ही टिफिन बनेगा. अगर बच्चा रात के 4 बजे भी आता है, सुबह के 4 बजे, रात के 10 बजे आता है, he has to be started on TPN. ठीक है, कमरे को ताला नहीं मारना है. TPN room has to be ready, just like हमारे घर का किचन कभी बंद नहीं होता, वैसे ही TPN room कभी बंद नहीं होना चाहिए. Start with a minimum of 2 to 3 grams, because 1.5 gram is something which is required for the metabolism of the body. If you are giving less than that, there is not going to be any positive balance. And increase it within 2 to 3 days to 3 to 4 grams. And same is true for the lipids. Lipids do not increase risk of infection. ठीक है, every time we think infection हो गया, पहले अमाइनो एसिड बंद कर दो, फिर लिपिड बंद कर दो. शुगर ज्यादा हो गया, सबसे पहले अमाइनो पे हाथ आता है, अमाइनो एसिड बंद कर दो. ठीक है, that should not be the case. And remember that fortification should be a norm rather than exception. All VLBW babies, they should be fortified, because human milk in itself is not sufficient to meet protein calorie requirement, and fortification should be started as early as possible. And there is enough studies from India also, including from MAM's unit, that fortification can be started early without increasing the risk factors. So in a nutshell, the main aim of this slide is that we have to do multiple small steps to gain big results. Don't wait for some ki kuch jadoo chamatkar hoga to unit ke outcomes better honge. Neonatology is all about simpler, smaller things, doing multiple times or doing multiple things together in a simple way. Keep things simple and you are going to have on the best results. Machinery, higher modes, higher machinery, they are not going to change your outcome. So similarly, in antenatal, good antenatal care, antenatal steroids, KMC, non-nutritive sucking, although they do not cost you anything, but they give you rich dividends. Similarly, आपके staff, they have to be motivated that these things are useful. Unless and until your staff is motivated, they are not going to motivate mothers, and they are not going to practice it. And similarly, TPN should be started early, right on day one. Men should be started on all babies, and you should be aggressive on feeds rather than a defensive approach. Now there is something हम prescribe तो करते हैं, but as that actually reach the baby, सबसे पहले transfusion दिया, सबसे पहले fluid बंद करो, TPN बंद करो. कभी कभी यूनिट्स पे एक ही इन्फ्यूजन पंप बचा होता है. अब उस इन्फ्यूजन पंप से हम इसको एंटीबायोटिक, 4 एंटीबायोटिक तो हर बच्चे को नॉर्म चल ही रही होती है. पहले एंटीबायोटिक देनी है तो टीपीएन तो बंद होगा ही, एक इन्फ्यूजन पंप है. सबसे इजीएस्ट वे है कि अमाइनो उनको तब तक बंद कर दो. ठीक है, बच्चे ने शुगर कम हो गया, पहले टीपीएन बंद कर दो. ठीक है, नोबडी ट्राइज टू मॉडिफाई द टीपीएन इन एक्चुअल. कल की कल देखी जाएगी, तब तक GR 10 से 12 कर दो, अमाइनो बंद कर दो. अच्छा नहीं ठीक हो तो लिपिड भी बंद कर दो. ठीक है, so that should never falter with the TPN. Remember that is just like an umbilical cord for this baby. ठीक है, do not stop TPN just for the blood transfusion. एंटीबायोटिक देना है तब तक बंद करो, या for other reasons. And remember, you should always ask, plot the charts, ask yourself, why is this baby not growing well? Do not find reasons to stop feeds, but in fact find at least one reason to start the feeds. ठीक है, come out of NEC phobia. ठीक है, do not do regular aspirates, give aggressive enteral as well as parental nutrition. Fortification should be a norm rather than exception, and always calculate calories and proteins as a part of vital monitoring. Just like we have vital monitors, similarly you should have a nutrition monitor. Despite having so many good players in the team, we have always failed to win a major ICC tournament. Why is it so? This is because of our defensive approach. The aggression is the best defense. Unless and until we realize that, we are not going to win. So my key conclusions for this talk is, remember that postnatal growth failure will be a norm if you do not do these simpler things and on regular basis. Growth faltering is not only causing harm in short term, but it's also going to affect the long-term outcome of the baby. And optimizing enteral nutrition and being aggressive on nutrition right from the labor room is the key concept. That is, prevention is better than cure. And you should aim at least a protein of 4 grams and calories of 120 to 130 by the end of the first week. And please start plotting and start reading these growth charts like you are interested in reading blood gases and graphics. Thank you.